Start by talking about cardiac arrest. Cardiac arrest is when the left ventricle stops pumping blood, causing a drop in blood pressure that leads to a patient collapsing. The technical definition is the sudden cessation of cardiac activity with hemodynamic collapse. And usually when people have a cardiac arrest, it's because they have developed one of four underlying cardiac rhythms, and I've shown all four of these on the screen here. First one is ventricular tachycardia, second one is ventricular fibrillation, third one is called pulseless electrical activity, or PEA. This means that QRS complexes are being generated, but there is no pulse. That's why it's called pulseless. And then the final one is called asystole. So patients who have any pathologic process that leads to one of these four rhythms will often collapse, and that's called a cardiac arrest. ACLS stands for Advanced Cardiac Life Support, and this is the algorithm, in other words, the steps that you follow when you are treating someone who has a life-threatening cardiac emergency like cardiac arrest. Generally, the ACLS protocol is a series of clinical steps that are taken when you encounter an unresponsive patient. This is a picture of people practicing the ACLS protocol in a dummy here. You can see that this man is doing chest compressions. Someone else is using a bag to ventilate the patient. And these are all components of the ACLS protocol for treating life-threatening cardiac emergencies. Generally, the ACLS protocol is applied when you encounter a patient who is unresponsive and has no pulse. And when this happens, the first thing that you want to do is call for help. And this often comes up on board exams. They will describe an unresponsive patient. The correct answer of what to do first is not deliver a shock or administer a drug. It's always to call for help. And that's because you want more than one person present when you're trying to resuscitate a patient. After this, the next step is to start chest compressions. This is also called CPR, or cardiopulmonary resuscitation. And what you're doing when you compress the chest is you are squeezing the left ventricle and forcing it to pump blood. Basically, you are doing the work of the heart because the heart is unable to do that due to cardiac arrest. After CPR, you want to apply oxygen. And then finally, you want to attach a heart monitor and defibrillator. This is an image on the screen of a heart monitor defibrillator. These are found throughout hospitals. And this step is very important because what you're going to do from this point forward is going to depend on the underlying heart rhythm that is present in the patient. Once you've done those four steps on the last slide, the next thing you want to do is examine the patient's cardiac rhythm on the monitor and determine whether or not it is shockable. And what do I mean by shockable? Well, these two cardiac rhythms on the left side of the screen, ventricular tachycardia and ventricular fibrillation, are shockable. That means you can deliver an electric shock to the chest of the patient and potentially restore normal sinus rhythm and normal cardiac output. And that's why one of the first things you want to do is apply a monitor and see if the patient has one of these two rhythms. If the patient does not have one of those two rhythms, if instead they have PEA or asystole, these rhythms are not shockable, and therefore you don't want to administer a shock. Shown on this slide is the ACLS algorithm for the management of patients with cardiac arrest. When you're treating a patient with cardiac arrest, the goal of treatment is to achieve return of spontaneous circulation, or ROSC. And you'll hear this term used clinically, so you should be familiar with it. So when you encounter a patient who has cardiac arrest, the first thing you want to do is all the things we've already talked about. You want to call for help, you want to place the patient on a monitor, and you want to begin CPR. The next steps after this depend on the underlying rhythm. If the underlying rhythm is ventricular fibrillation or pulseless ventricular tachycardia, then the next step is to shock. On the other hand, if the underlying rhythm is asystole or PEA, a shock is not advised because these are non-shockable rhythms. In patients with VFib or pulseless VT, after you deliver a shock, if you achieve return of spontaneous circulation, then you stop. If, however, the rhythm persists and the patient remains in cardiac arrest, then you want to go back to doing CPR. Because remember, when you're not doing CPR, you're not circulating blood through the patient's body. As you're doing CPR, you stop every 2 minutes to check the rhythm. If the rhythm remains VT or pulseless VF, then you want to shock again. In addition, while you're doing these rhythm checks and repeat shocks, you can administer epinephrine every 3 to 5 minutes, and amiodarone is used in refractory cases to try and terminate the ventricular tachycardia or ventricular fibrillation. In contrast, if you have a patient with asystole, you don't deliver a shock, as we already said, you continue CPR, you can administer epinephrine every 3 to 5 minutes and do rhythm checks just like you do in patients with VFib or VT. And then beyond these things, the mainstay of treating asystole or PEA is to try and identify a reversible cause that you can stop to try and get the patient to have a return of spontaneous circulation. So shown on this slide are the reversible causes of cardiac arrest. Most of these are fairly obvious. Patients who have severe hypovolemia or hypoxia can have a cardiac arrest. Acidosis and potassium abnormalities can cause cardiac arrest. Severe hypothermia can cause cardiac arrest. And then a number of pathologic conditions are sometimes associated with cardiac arrest. These include myocardial infarction, tension pneumo, cardiac tamponade, and pulmonary embolism. So in real life, when you're running a code and following the ACLS algorithm, what you want to do in the back of your mind is think about the patient and think about which one of these underlying reversible causes may have led to the patient's cardiac arrest. If you can figure out, for example, that the patient is likely severely volume depleted, then you can treat that by giving volume. Same thing for some of these other causes listed on this slide. So when I'm involved in a cardiac arrest, I'm making sure that someone is doing chest compressions, that we're checking the rhythm and delivering shocks. But while that's going on, in parallel, I'm thinking about these causes on this slide to see if one of them is likely to have caused the patient's cardiac arrest, and therefore, if one of them is potentially treatable. Now let's talk about ventricular tachycardia in a little bit more detail. Some patients who develop ventricular tachycardia are stable, and by this I mean their pulse is intact and the patient remains awake, and they have no evidence of hemodynamic compromise, things like hypotension or chest pain. If you encounter this situation, what you want to do is administer intravenous amiodarone, or alternatively, you can use other antiarrhythmic drugs like lidocaine or procainamide. But the most important thing to remember is that you do not want to perform a cardioversion. In other words, you do not want to administer a shock when a patient is conscious. You should never do this. And this often comes up on the board exams. They describe a patient with stable VT who is conscious. Even though VT is a shockable rhythm, you never shock patients when they're conscious because it is extremely painful. The correct answer for treatment of stable VT is to administer intravenous amiodarone or another antiarrhythmic. In real life, patients with stable VT sometimes pass out, so you can wait until they lose consciousness and then you can shock them, or you can administer anesthesia like propofol and then shock them. But the important thing is to never shock a patient who is conscious. Polymorphic ventricular tachycardia is a subtype of ventricular tachycardia where the QRS complex morphology varies over time. If you look at the bottom right side of the screen, this is an example of monomorphic ventricular tachycardia. You can see that all the QRS complexes have the same shape. On the left side of the screen is an example of polymorphic ventricular tachycardia. You can see that the QRS complexes change over time. Patients with polymorphic VT usually have multiple foci of abnormal electrical activity in the ventricle, and that's why all those multiple foci generate QRS complexes that change over time. It's an unstable rhythm that can lead to cardiac arrest, just like any form of ventricular tachycardia, and it's treated the same way as other forms of ventricular tachycardia. And usually polymorphic ventricular tachycardia occurs in patients who have myocardial ischemia. So for example, a patient with a STEMI can have ischemia to the entire anterior wall of the left ventricle. That often leads to polymorphic VT with lots of abnormal foci of electrical activity in the ventricle. Torsade de Pointes is a special subtype of polymorphic ventricular tachycardia that occurs in patients who have a prolonged QT segment on their surface ECG. If you look at the bottom right side of the screen here, this is an example of a very prolonged QT interval. So the QT interval begins at the onset of the QRS interval and it ends at the end of the T wave. And a normal QT interval is about 400 to 500 milliseconds. This patient's QT interval is over 600 milliseconds. It's over 3 big boxes wide, and that is severely prolonged. And patients can develop a prolonged QT interval if they have abnormalities of potassium or calcium, or if they are taking certain drugs, especially certain antiarrhythmic drugs. When the QT interval becomes prolonged, patients are at risk for developing this arrhythmia, Torsade de Pointes, which is a subtype of polymorphic VT. It's called Torsade de Pointes because that term means twisting of the points, and you can see that the QRS complexes go from very large to very small, and that is believed to look like a twisting of the points. And basically, this is just a special subtype of ventricular tachycardia, and you treat it the way you would treat any form of ventricular tachycardia. If the patient is hemodynamically unstable, you administer urgent defibrillation. The one special thing about torsades that you should know, especially for your boards though, is that when patients have recurrent episodes, you can treat this with intravenous magnesium sulfate. For reasons that are poorly understood, magnesium sulfate works to suppress Torsade de Pointes. This is the only arrhythmia where we use it. So in a board question of a patient having this arrhythmia who has a history of something causing their QT segment to be prolonged, the right answer is often magnesium sulfate. So lots of cardiac arrests happen outside the hospital, and when this occurs, there's often no one around to perform CPR and resuscitate the patient. So many times, patients with out-of-hospital cardiac arrest do not survive. The time to resuscitation is the strongest predictor of survival of an out-of-hospital cardiac arrest. If there is someone around to begin resuscitation in a short period of time, that leads to improved survival. If it's a long time until someone responds to the cardiac arrest, there's a poor prognosis. This is the most important factor to determine whether or not patients survive. And then beyond this, there are many other poor prognostic signs. I've listed a couple of them on this slide. If the initial rhythm is PEA or asystole, that's a bad prognostic sign. If spontaneous circulation does not return after 5 minutes of CPR, that's a bad sign. And then, of course, advanced age is also a bad prognostic.